And we are just simply thrilled to have you here at the Health Museum. And we are more thrilled to partner with the Women's Fund because we've got significant issues in our community regarding women and children that we'd like to tackle and we would like to expose and to make people educated and aware of. And this topic, maternal morbidity, is like none other because for many, it makes you think back to the 1800s that there is no way that there is maternal morbidity during childbirth. And so we've got excellent panelists here who are going to shed light on such a critical issue. And I will, without any further ado, turn this over to Dr. Wanda Mott, who will introduce the panelists as well. And welcome again. Thank you very much for being here.
Thank you. Well, good morning. Good morning. Welcome. Thank you so much for being a part of this panel. Certainly, I am Wanda Mott, and I have the privilege of being a board member of the Women's Fund. The Women's Fund was established in 1979, if you don't know about us, and we've been servicing the women and children and girls in the Houston community for over 30 years. We are dedicated to providing medical information and research on women's health and making sure that that information about mental, physical, and emotional problems in women is distributed throughout the community. We do that by these talks. We also do that by many other opportunities that we have in the community. So I want to take a look at something here that we're really encouraged that we can make a difference in, which is maternal mortality. We're interested in giving the most up-to-date information about medical illnesses for our women and girls here in the Houston area. But we look and we see that we want them to be advocates for their own health. But maternal mortality in Texas is the reason that we're here and why it is such an important factor. So I want to welcome you, but I also want to give you the information, the basic information about our maternal mortality here in Texas. So let's begin with a definition. What is maternal mortality? It is defined as from pregnancy to the first 42 days after delivery, maternal deaths. That means deaths of our mothers. That's an awful difficult thing to actually swallow. But then when we look at that, we're not only talking about that 42 days, but we're extending that from related maternal mortalities to actually associated maternal mortalities. And we'll talk about that. But let's look at what is happening in Texas and compare that to what is happening in the United States. I'm going to start with my first slide. So here with Texas mortality, we're looking from 2005 to 2015. I don't know if you can see that. How do you bring it down? Can we bring that down? Please. Let's bring it down.
Okay, y'all are gonna have to.
So you guys can see that, right? Okay, so let's look at it. All right, 2005 to 2014, and we even have numbers now for 2015. If you look at that for us, now that is the deaths or mothers from pregnancy to 42 days per 100,000 live births. So in 2005, when we get it, hold on.
So sorry. We're trying.
There we go. You're doing
fine.
fine. You're doing fine.
Mm-hmm.
So you bring it down just a little more so they can see the top. Yeah. In 2005, we were in Texas at 8.6 per 100,000 live births. If we superimpose the United States, the whole country, we were at 15.1 in 2005. That's per 100,000 births. But if we continue to watch that red line, by the time we get to 2014 and 15, we have numbers for, we're at 32.5 per 100,000 births. whereas in the United States, we're at 20.9. So that tells us that Texas has the highest maternal mortality for the developed world. That's an important fact, ladies. That's an important fact. Certainly, what does that mean for us? That means that something is going on in our state that is not allowing us, and we have not made the changes that are necessary to save the mothers in our community. So what are some of the things that happened? We looked at this timeline. What happened between 2005 and 2015 in Texas? Yeah, let's look and see. One of the greatest things that happened, and you can't see it at the top, but it says illness burdens in chronic illness. When we look at Texas from 2005 to 2015, we see that 3 diseases have increased. Obesity has gone up 25%. Diabetes has gone up in Texas 45%. And hypertension has increased in Texas 20%. So these comorbidities or these chronic illnesses, having our mothers enter a pregnancy with these uncontrolled diseases, increase our risk of maternal mortality. So these are facts that our women need to know. And certainly they need to be women in Texas, and not just in Texas, but everybody. Nobody goes to the doctor or to the gynecologist unless they're pregnant, okay? That's when they go. But that's something we have to teach the women in our community. And that's why we're here, that there is a continuity in care that must take place, because many of our mothers, when they begin their pregnancy, are at increased risk. So what are some of the other factors? Let's look at this red line. Well, ethnicity is an important factor, and we need to know these facts as we begin to try to make changes in our community and lower this level of maternal mortality. Well, we got 3 lines, and we have Texas's line. Texas is dotted, okay? We have Hispanic, and we have white, but that big red line is African Americans. What that shows us is that African American women have a greater risk of maternal mortality. And when we look at the demographics of these women, they are usually 40 plus, and they are of lower economic or socioeconomic status. And by that, I mean not only financially, but also educationally. So these facts are things that we need to use not only in the community and encouraging people to know what's going on, but also in our hospitals in the ways that we assess patients and try to prevent it. So, okay, so we got the information on what the factors are. Now, let's look at what the causes are. Maternal mortality deaths within the first 7 days. When we talk about during the pregnancy and in the first 7 days, the top causes are here. If you look, most of them are associated with hemorrhage or uncontrolled bleeding. They are associated with hypertension or certainly eclampsia, which is seizures during pregnancy. They are associated with cardiac events, with emboli, not only, which are clots, not only from the amniotic fluid, but also in the brain, which is a cerebral vascular accident, and also pulmonary emboli. Now you can see, if we're talking about pregnancy to the first 7 days, then we're really talking about things that are happening in the hospital. So your distinguished panel is going to tell you some of the things that Texas has adapted to make sure that we are moving toward changing these numbers in Texas for maternal mortality. Because when we say mortality, we're talking about mother's deaths. We're losing women in the childbearing age to maternal mortality on a day-to-day basis. Now, the next slide I want to show you is the top causes of confirmed maternal deaths here in Texas. Now, if you look at the first one, it's 17%. But what is it related to? We talked about the first 7 days out of pregnancy. Now, we're talking about a 365-day period from delivery, okay, until this postpartum period is over. The drug abuse, okay, and drug overdoses account for 17%. So we need to look at some behavioral changes in our community as well. Now take out the ones that we already talked about. Take out the cardiac, take out the hemorrhage, take out the hypertension, take out those, because those were already in that 7-day period post. But look at the ones that are taking place after that time period, all the way to the 365 days. So what do we see? We see drug overdose, and much of that is associated with opioids. And certainly you've heard lots about opioids in our community. What else do we see? We see homicide. So we've got behavioral changes and domestic abuse that is not being assessed in our communities before. We've got suicide. And does that mean that we have postpartum depression that is not being taken care of as these ladies leave and go on to take care of their babies? So I think we have a lot of questions that we need to answer, not only to understand that these are factors, but what do you do when you get the information? We're glad you're here because you want to get the information, but what do we do as the community to make sure that this drops? Because Texas should not have the highest maternal mortality in the world. We have the greatest medical facility in the country in here. We have people coming from all over the world to be treated at this medical center. So there is no way that we cannot prevent this. So when you leave here, what you want to do is you want to get this information out to anybody you know. We need to know, and your mothers, your grandmothers, your dads, your uncles, your cousins, everybody, your boyfriends, everybody needs to know that it's important. But not only is it important, but we have to seek mechanisms of prevention. So how can we do that? Well, one of the things that we can compare is we can look at who these people are. When we look at the drug overdose, and that's the one I wanted to talk about, when we look at the demographics of these women, they're usually 40 plus years of age, they're white and lower socioeconomic group. The more facts we have, the more we can attack the problem. So what has California done that Texas has not done? And maybe we can take some hints. So if we look back here between 2005, 2006, we were running neck and neck. But look what happened. We kept going in the red and they went down. What happened? We need to make some changes. If you look down here, there's a description of what's called an obstetrical hemorrhage. And remember, hemorrhage was in that first pregnancy up to 7 days. Okay, and what they did is they established toolkits. Toolkits are protocols that take place in the hospital when you know that you have someone that has this risk. So different things are done to lower that risk. They established toolkits also for hypertension and eclampsia. So these are being utilized within our hospitals, and certainly your panel will talk to you about some of the things that we are doing. But does that mean, ladies, that perhaps for those ladies that are in the 365 related or associated maternal deaths, that maybe we need toolkits for drug overdose. Maybe we need toolkits for depression. Maybe we need toolkits and protocol for women that are actually in domestic situations. So it's time for us to put our thinking caps on. It's time for us to dig in and change this catastrophic level of maternal mortality, 32.5 per 100,000 life births, and bring it down to what it can be, which is the lowest in Texas history. So 50% lowering of this is possible with prevention, and that's what we need to begin. So I want you to sit back. That's a lot of information. I'm through. Okay. I want you to sit back and relax and enjoy your lunch. But I want you to process the information that this distinguished panel is going to give us. I want to take the time to thank you for taking your lunchtime to be with us and begin to help us to make the changes that have to take place in our community. Our mothers are dying, and they don't have to die. I want to thank certainly the Women's Fund for listening to my concerns about maternal mortality and morbidity and establishing this doctrine. And most of all, I want to thank the panel for their expertise. They are volunteering tremendous amount of time because they know how important this is. And not only are we changing the things that are happening in the hospitals, and they'll talk about that, but they're interested in changing what's happening in the community. So prevention is available. So thank you for being here. Thank you for spreading this word. And thank you for being a part of our change.
Hello, everyone. I don't know if my mic is on or not, but
I can speak loudly for sure. I'm the mom of 3 teenagers. My name is Gina Gaston, and I too am on the board of the Women's Fund and also serve as a news anchor at Channel 13. I'm happy to be here today to just lead the panel discussion to help usher us through the questions. We want to begin by having our distinguished board here introduce themselves. I first want to bring regrets from Dr. Toy, who had hoped to be here but had a family medical situation that didn't allow him to. So he is with us in spirit. And I also want to give a shout out to our Facebook community. Thank you for tuning in and watching us here live in Houston, Texas from the Government Health Museum. So let's begin with Dr. Sean Blackwell. If you can introduce yourself, and we'll come on down the panel.
Good afternoon. It's a pleasure and an honor to be here. I am I'm an obstetrician gynecologist, maternal fetal medicine specialist. I am the chair of the Department of Obstetrics and Gynecology at Government Medical School at UT, and have a clinical and an operational interest in reducing our maternal mortality and not just mortality, but certainly morbidity in these our moms getting sick and having lifelong problems. Picking that up better?
Hello, mic check. Here we go.
Okay.
Mic check, take 2.
thank you all for being here. I'm Jim Pankey. I'm a nurse. My whole clinical background is maternal child. I've worked labor and delivery, part of newborn nursery. Currently, I work at Harris Health System or in a public health capacity. I do data analysis and GIS mapping. I'm a member of the Maternal Mortality Morbidity Task Force, and I also participate in many of the organizations within Harris County that are working on maternal child health. I'm the co-chair for the Healthy Babies Are Worth the Wait with the March of Dimes. I sit on the Nurse Family Partnerships Board. I'm a member of Impact. It's a collaborative of individuals and organizations in Harris County working to improve maternal child health and care.
Good morning. I'm Carla Ortique, and I'm an OB-GYN here in Houston. I'm going to start off with a story, and I think there's one slide perhaps that will show up. Because it explains or at least the origins of my interest in this problem. In 1999, a young woman was pregnant, and she went to see her doctor on a Thursday and had shortness of breath, a little bit of swelling, and just a little bit tired. Her blood pressure was elevated, and she was advised that she had some mild elevation of her liver function test. And she was told to go home and to rest and to come back in to be checked the following Monday. That Friday, she went by her stepmom's house, and upon seeing her, her stepmom took her to the emergency room, and she was admitted, delivered by C-section, and spent 4 days in the ICU. That young lady was my stepdaughter, and we delivered a beautiful baby girl who may or may not appear on the screen. The bottom line is everybody doesn't have an OB-GYN for a stepmom, and so we have to encourage the community as well as our moms to recognize that if you don't feel well, if you are feeling sick, even if you're initially told that everything is okay, but sometimes you have to really advocate for self. She's an example of maternal morbidity.
our outcome was good, even though she spent 4 days in the ICU, during which time I got to know my granddaughter a lot better than she did. But she came out alive on the other end. We know that for every death, there are approximately 50 to 100 severe morbidities, which is what that represents, her story represents. As Dr. Mott mentioned, African American women do bear the greatest risk in both Texas and the U.S. There, that's my granddaughter. She's beautiful. She's at UT now, and she wants to be a doctor. The quote that's up there, I think bears reading. It was given by one of the past presidents of the International Federation of OB-GYNs while addressing the UN. And what he said was, women are not dying because the diseases cannot be prevented, but because societies have not decided that their lives are worth saving. He said that back in 2006 when the U.S. maternal mortality rate was actually still low. It's really sad to me that it is now applicable to our great state. As was mentioned, approximately 50% of maternal deaths are preventable. So my training, both in primary care as well as in obstetrics, service through the National Medical Association, which is an organization dedicated to the elimination of racial and ethnic healthcare disparities. The Texas Medical Association, which is organized medicine, I held leadership positions there, as well as my faith, my heritage, and my understanding that these diseases, these deaths are preventable. They form the basis for my commitment to spreading the word and to finding solutions to the problem. I'd also like to add my thanks to the Women's Fund, to the McGovern Health Museum, and to all of you for coming out this morning. I thank the Women's Fund for sponsoring us, and I look forward to a lively discussion.
Okay, thank you, Dennis. I think you can maybe do this mic. Say anything? No. These.
Yeah, don't really get closer.
I'll use this one. Okay, let's get right. We've done a good job of kind of laying out the challenges ahead and the challenges that exist right now. Talking about to what extent it's preventable, I think you used the number 50%. But let's talk about specifically this issue of the drug overdose issue and why we're seeing a rise. I'm going to try and do two answers for one question so that we don't spend too much time on one issue. So I'm going to start on that end. Mr. Blackwell, if you could first weigh in on that.
Well, I think that when I think of the data that we're seeing related toward overdose, related to as a cause of maternal mortality, I think a couple thoughts. One is that we're finally collecting data to know what's going on. One of the greatest challenges we've got about being able to work on or fix or address the problem of maternal mortality is we're not so sure on exactly when our women are dying and what they're dying from. So we're finally got some data related to overdose, and overdose is really complicated. It's complicated because it certainly can involve substance abuse and overuse, and it interacts with mental health issues. So that's for sure. I think that we're finally collecting some data long beyond just 42 days after a woman has her baby, and that's where we're probably seeing the greatest spike of maternal deaths related towards overdose. I think with all of the attention related towards opioids right now, I think that's important, but a lot of the drugs that our patients are taking and dying from are unrelated. There are other medications, and we can't forget that. And I think finally, this is a societal epidemic. Women, and especially after they have their baby in their families, they're not immune to what's going on from a society standpoint, and they're probably even more vulnerable to these sorts of things due to access and resources and those sorts of things. So, that's sort of what I think about The other aspect of it is right now, the majority of women really, and the majority of patients in general, don't have great access to high-quality mental health services, especially our underserved patients. Getting mental health services is really, really hard. It's hard in Texas, it's hard all across the United States, and clearly it's affecting our postpartum women.
I also think that in addition to what Dr. Blackwell says, it's part of what's happening in society. I think it's not just in women or who are pregnant or have had a baby, but when you look at the whole issue for our whole society, this is, we hear about the opioid epidemic. And so I think this is actually just bringing it, more to our attention. It also is not just what happens while they're pregnant. They may have had medication or being given opioids for something, an injury or surgery or something before, and they're already in that era of addiction. And I think this just leads us to make sure that we are screening. Are we doing effective screening? And then, again, for us to look at what do we have for referral services? Where can we get the moms? How can we help them? What differences can we make? So I think, as Dr. Blackwell said, getting the data has had sharply focused us in the issue related for women. And we're also working on what can be done to prevent this. The Council on Safety for Women's Health is working on a funding for substance use disorder, and this would be something that the state is going to be taking on as well. And I also think another really important thing we need to talk about is the language around this, because when we talk about, drug abusers versus substance use disorder, I mean, I'm really learning a lot about this. I have to say this wasn't an area where I knew a whole lot, but my knowledge has increased significantly. And I think even just looking at our language and what we say and how we say things can make a difference in helping these women.
Dr. Ortique.
I just wanted to add to what June was saying. Texas has seen the opioid crisis as being imperative to be addressed, and partners at the Department of State Health Services are involved in the creation of an opioid safety bundle, which is supposed to be rolled out in June of this year. And so that is a really exciting development for us, and it was an honor for the department to be involved in the creation of that. It is a sign of the recognition of the importance of this problem. It was alluded to, many women during their pregnancies do everything they can to take care of the pregnancy. And so they may stop using drugs even during the course of the pregnancy, and then afterwards are somewhat, we call it drug naive. In other words, it's been out of their system long enough that a smaller dose, a dose that would not have killed them at other times, might then cause their death. And so there's a lot of information about that, as well as the fact that the opioids may be a proxy for mental health illness, which has been mentioned many times. During your pregnancy, you may receive treatment for depression, anxiety, paranoia, schizophrenia, but then once you lose insurance, which is true for many of the women who are on public insurance after delivery, you have to find something else to treat the mental health issues that you have. And unfortunately, opioids are one of those something else's that are often found.
Dr. Mott, you talked about kind of a population at risk because of drug overdoses, but then you talked about another population at risk from kind of chronic health problems that they had pre-pregnancy, really. And I can talk a little bit about what's being done to address that, because there's a community that just getting pregnant unhealthy.
Exactly. And what's happening is, certainly in our communities, women go to the doctor, especially in the reproductive years, when they're planning pregnancy. Sometimes they go in before, sometimes they go in when they're already pregnant. What we